Good morning, everyone. Welcome to TeleShadowing. We are recording this session and live streaming it to YouTube. We will be having a Q&A session at the end, and you can ask questions in the YouTube Live and Zoom chats, and they'll be addressed.
Good morning, everyone. I'm honored to introduce our mentor for today, Dr. Sonia Sloan. Dr. Sloan is a force to be reckoned with. She serves as a leader in both the medical and religious communities. Dr. Sloan has established two specifically purposed nonprofit organizations which serve to empower others. She is also an accomplished author and speaker. I would now like to request Dr. Sloan to begin today's session. Thank you.
Hi, everyone. I'm so glad to be here with you guys. TeleShadowing. I mean, in the midst of COVID, we have to do what we have to do. So I'm very proud to be part of this presentation for you guys today. And today I'm going to tell you a little bit about what I do. I'm an orthopedic surgeon, which means I deal with broken bones, trauma, when you break things. Maybe you have a grandmother, grandpa that's had a hip replacement or knee replacement. I do that. So yeah, I cut people for a living and put them back together with power tools. That is my superpower. Next slide. So why did I go into orthopedics? A lot of times people say orthopedic surgery is a men's field, if you will. It's a man's world. Currently in the United States, there are only 6% of orthopedic surgeons that are women and less than 1% that are actually Black women orthopedic surgeons. But when I was in high school, I actually was running track and I did gymnastics as well as cheerleading. And I had, what you're looking at is a patella, that is the kneecap. And so it actually subluxes, which means it sort of moves to the side. And that's actually my MRI of my knee. And so you can see it was an injury and I was going to have to go under surgery. And I met this really cool doctor. He was an orthopod. His name was Dr. Black. And he was like, you should probably go into orthopedics. This is a really great field. You love what you do, you fix things and you move on. So there was like a acuity of it. You could fix things and be done with it and people got better and went on with their life instead of something like hypertension or diabetes where you never really fix that. Next slide. So what is orthopedics? Orthopedics is actually the surgery that concerns a musculoskeletal system, things like the spine and the joint, and how to repair those things. This is a child that I took care of at Shriners Hospital. The device he has on is called a halo. We actually fixed his neck because he had a genetic disease that made his neck unstable. And so once we fused it, he had to wear this for about 6 weeks. And genetically, his brother had the same exact thing. And so they underwent surgery. So Shriners Hospital is a phenomenal place for orthopedic surgery for kids. Next slide. So again, how many people are actually orthopedic surgeons? In the United States, there's approximately 30,000 practicing orthopods, 94% are male and 6% are female. And you can see a lot of times when I walk into the operating room as a traveling physician, most of the team I work with are men. So they're a little impressed or surprised when they see a Black woman walking into the operating room. Next slide. So how many years does it take to become an orthopod, an orthopedic surgeon? All right, let's go. Next slide. So you do 4 years of college. A lot of you guys are in this place right now. I actually did chemistry major. I had a bachelor's in chemistry, a minor in math. And this is at Texas Tech University. I was, the picture you see is me and my dad. I was the first Black homecoming queen at Texas Tech University, actually still the only, and that was in 1992. But 4 years of college, usually in a science field, but today a lot of people are actually doing bachelor's of arts as well. So you can do anything as long as you have some of the basic requirements like biology, chemistry, and biochem. Definitely some of the mathematics help, but not necessary. Next slide. So you got 4 years of college, then we move on to 4 years of medical school. And that's when you actually get your MD, your medical doctor, after you finish those 4 years. So the first 2 years of medical school are usually book training. You're actually reading, you're learning the basics and all that kind of stuff. And the last 2 years are usually clinical. So after those 4 years, you graduate and get your white coat. So 4 years of college, 4 years of medical school. So we're up to 8 years before you become a medical doctor. This is the University of Texas Medical Branch in Galveston, where I went to school. The building behind us, my class, is the oldest building in Texas, called Old Red. Next slide. And then I went to Baylor College of Medicine and I did my general surgery as the first year. And then I did 1 year of orthopedic surgery research. And then we did 4 years of residency in orthopedics. And then if you want to, you can do a possibility of a fellowship as well. So what happens on a regular day? I'll take you guys through to the operating room, okay? So we have 4 years of college, 4 years of medical school, and again, some people 5 to 7 years of residency. So you're easily at 14 to 15 years before you become an orthopedic surgeon. And so here we are in the operating room. And what does my day usually consist of? Again, you can see on the right side, there's a lot of power tools, drills, saws, that kind of thing. But sometimes it's very small, delicate, soft tissue things that when you're doing hand surgery, it's a little bit more fine-tuned. Next slide. So what types of specialties do we go into? You guys are looking at a hip replacement on the left side. And then the right side is the same patient who broke their knee. That's the distal femur right before the knee joint and shattered it when they fell. So there's different types of fields to go into in orthopedics. Next slide. So hand, of course, is all these are subspecialties that you would do a fellowship in. And so hand, again, is minor trauma, big trauma, reimplant, a lot of times in kids when they're young. You also have adult hip and knee. You have shoulder surgery, elbow surgery. Trauma is a big one. So if you live in a major city, most ortho traumatologists are going to be in your major medical centers to take care of level 1 traumas. Sports medicine is huge. Everyone wants to go into sports medicine because it's always popular with teams. But what you don't know is usually those doctors actually pay those teams to actually represent them because it's sort of an honor, if you will. And then spine surgery, one of the harder disciplines that also shares other disciplines like neurosurge also does some of the spine surgery, so there's an overlap. Orthopedic surgery in pediatrics is its own specialty. And then you have foot and ankle and musculoskeletal. Next slide. So what's the average income when it comes to orthopedic surgeons? So that's what everyone really wants to know, right? Everyone wants to know, how much am I going to get paid after all these years of, I'm dropping off kids, sorry guys. How much am I going to get paid after I do all of these years of training and practice and that kind of stuff? The average income for an orthopod that's like full-time practice going hard, you guys, is about $600,000. And then again, you go down and you approximate if you're working part-time or whatever else. So it's a good living. Don't get me wrong. It's a good living, but you are really working hard. Next slide. So what does that day look like that's going to get you that higher price or that dollar amount that you think? That starts really, really early normally on most days. So that means you're getting up at a 5 or 6. You're at the hospital definitely by 6:30. Most surgical cases are going to start earlier than 7:30, sometimes 7, depending on what your day. And that also includes like some things like clinic. Next slide. So normally I would start looking at x-rays from anything that I'm going to be operating on the left side. You see the x-rays that we look at, review your x-rays, everything from templating them, making sure you have the right equipment for the surgery itself. Then you have things that are clinical days, like most of the cases you see in clinic are going to be, I call them the everyday bread and butter cases. So it can be everything from a carpal tunnel to little kids breaking their arms on monkey bars and elbows on trampolines and that kind of stuff, and putting cast on. This is one of my patients that was like his 5th cast because he was that little kid that would get it wet, or he had stuck something down the cast and it was irritating him, or he said it was itchy or too tight or too loose. So those are all the things that we have to contend with. And then definitely surgery. One of my things I love to do is go into surgery and taking care of patients. It's not just about cutting them. It's also the patient care and your bedside manner that is very important for your retaining patients and your patient population. Next slide. So how long does your ortho cases usually last? Was one of the questions I've had in the past. On the left side, you see me. I'm doing actually a hip replacement. putting a hip nail in, which is basically where it's almost like, think about a pencil inside of a tube. And so we put the pencil or the rod down the tube to make it more stable with a couple of screws and that kind of thing. And so those surgeries can last 2 to 3 hours. On a good day, an hour and a half. On a bad day, 3.5. You have a lot of blood loss. It usually takes a team of your anesthesiologist who's controlling the patient's airway and putting them to sleep. Sometimes they do a spinal. And then you have a circulator in the room that's like, if you need something, they can go get it and they're not sterile. And you have your OR tech. That's the person that's standing next to you that's handing you the instruments of what you may need. And then you have to have x-ray in the room that's taking live pictures while you're doing everything that you're doing. All right. And then also the rep, usually the rep from the company of whatever implant you're using is in the room to make sure everyone knows what they're doing. All right, next slide. And then there's usually clinic and the emergency room. So in the emergency room, you may be taking care of patients that have dislocated a joint, like a shoulder or elbow, a hand, wrist, as well as they're putting splints on. Maybe it's just checking a hand for a wound infection or a leg infection. Sometimes we admit patients. And then again, it could be operating room stuff that we're taking care of, small things. And then even looking at x-rays and giving your consultation to people in the emergency room, that kind of stuff. And then clinic every day. Patient comes in for knee pain. I fell and broke my ankle or twisted my ankle, that kind of stuff every day. So your day could be surgery, ER, and clinic all in one day, 12 to 14 hours a day, easily. Next slide. So I'm currently on the Indian Health Reservation, Navajo Nation, that is in New Mexico. And again, my average day is usually 12 hours. Some days are longer, some days are shorter. But for the most part, I am in surgery 2 days a week. With COVID, that was slowed down to just emergency cases. We're picking back up again. So it's gotten busy. Patient-wise, you can see anywhere from 10 to 20 patients, up to 25 patients a day for small things, and then consultations as well. We started doing telemedicine as well. So I'm getting on the phone to give consultations to other patients and even doctors about what to do and how to do that. Next slide. So what other specialties must you learn? X-ray. You have to learn as an orthopedic surgeon, you're also learning radiology. And so we always joke about with our radiology friends that, I can read an x-ray better than some of them can, because that's what I look at. So part of my book is called The Rules of Medicine. Rule number 1 is trust no one. And that even comes to x-rays when I talk about x-rays, because I'm reading something and what they're looking at and what I'm looking at are usually two different things. So you will learn how to look at radiology and x-rays, CT scans and MRIs as an orthopedic surgeon, because sometimes you'll be the first to see it before even the radiologist can do the official read. So definitely learning other subspecialties. Next slide. So what else do I do? I am a traveling surgeon for a reason. I have other passions in my life. And so I think my occupation allows me to do other things. I am a mom of 3, and 2 of which there are dancers. I'm driving around now, dropping off dancers, and their schedules are just as busy as mine usually. I'm also an author, as you guys may have read. I have a blog that I write for a couple of different companies, as well as I do speak at multiple universities and that kind of thing throughout the year. We've done a lot of virtual. These were one of the live classes at Howard University in DC and a couple other places. And then recently, I'm the vice president of Black Women Orthopedic Surgeons. It's the first group to focus on mentoring to the next generation of Black women orthopods, since there's so few of us. Next slide. And then as you guys can see, my family in the middle. My husband is a senior pastor of a mega church here in Houston, North Houston. We have over 5,000 members. And so with that, we do a lot of other activities, including our Sloan STEM plus Arts. It's a nonprofit that focuses on minorities in medicine, science, technology, engineering, math, and the arts. And so by giving them early exposure, hopefully we can increase the number of minorities that go into STEM fields, which is a financial sustainability in the future, because these are usually six-figure salaries. And then on the right, you guys can see we built a clinic in Haiti, which is a medical clinic specifically for the Haitian population. Port-au-Prince on the Legon Plateau services approximately 100,000 people, men, women, and children each year. And it was with New Missions Organization through our church that we did this. So yeah, we have our hands in a lot of different things, but it gives you, I believe, more flexibility to do what you want to do in life, not just medicine. So there is room to do more. Next slide. And again, I wrote a book called The Rules of Medicine. It's a medical professional's guide to success. The book was because my mom was a nurse, and I never saw a Black doctor. I never saw a female doctor growing up. It wasn't until I hurt my knee as a junior that I actually saw a doctor that actually I thought cared about who I was, and that I was able to do some other things. And I learned as I went through my, undergrad, medical school, and residency training, there's a lot of things that are known, a lot of things that are said and spoken or unspoken, but no one's ever really documented them and put those in the same place. And a lot of these things actually apply to life in general, but some of these are specifically to medicine. And of course, my favorite rule is rule number 34, pay it forward. It's about inspiring others to do what you do and help them along the way. And that's why I'm here today on the TeleShadowing, hoping you guys can be inspired to be an orthopedic surgeon. Thank you, guys.
Thank you very much, Dr. Sloan. Sorry I was having technical difficulties. I really appreciate you taking the time to talk to us and sharing your life story. So we do have a couple of questions from the group. So I'm going to start off our Q&A session now. And if anyone has any questions, they can feel free to ask now.
Okay.
So to begin, this is kind of about the machines and robots when it comes to orthopedic surgery and how they can help the orthopedic surgeons, such as the Da Vinci surgical system. And so what are your thoughts on these robots for when it comes to the best patient care?
So right now, as far as robotics and AI in orthopedics specifically, I can speak to that. It's with joint replacements. So like the total knee replacement is phenomenal. And so it's had it's gaining popularity, it's gaining notoriety to have better and more precise cuts. It's templated specifically for every patient. So when you have that type of custom implantation and surgical cuts for a patient, I think there's definitely room for better outcome. The issue right now is, for that type of robot, you definitely have to be joint subspecialty. So you'd have to go into a joint fellowship 1 year, sometimes 2 years. And there's a learning curve. You have to start here. So, you may do 4 or 5, but if you're doing 20 joints a week and you're using this machine, of course, proficiency becomes a lot more important. As a whole, I think orthopedics is still a little behind when it comes to technology. And that's definitely room for entrepreneurship. I'm definitely an entrepreneur, a serial entrepreneur. And I believe that if you have everything from apps to machinery to implants, that kind of thing is just now at the forefront of really changing in orthopedics. So it's definitely a genre to look into and to go into. Robotics as a whole in medicine is also increasing, like in general surgery, in urology and that kind of thing. So definitely exciting, definitely on the forefront, still evolving. Yes, but great. I think they're great.
Thank you. And just as a follow-up question to that, will it affect any orthopedic surgeons' jobs in the future, do you think? I know that there's still much more room for improvement.
No, I think because you still have to have, when we go back to basic things, like there still has to be basic interaction with a human being. There still has to be basic bedside manner. I think the robotics and the AI comes into planning, surgical planning. In the operating room, I think it's going to be a group effort, if you will. Still someone needs to make a skin cut because there's certain things that robotics will not be able to interface with, so it's one thing to be able to cut the skin for 4 centimeters above the joint and 4 centimeters below the joint. But what if that patient has a mole or a tattoo or whatever it is, that there's little things that robotics are not going to pick up on that is still the human brain, human eye will. So I think there's going to be an interface between the two, but makes the surgical outcome that much better.
Thank you. And this question is about how long orthopedic surgeries typically last. So how long has been the shortest case you've had and the longest?
So the shortest could be like a we call hardware removal. So it could be like a pin that you go in. And so in the hospital I'm at, you cannot do hardware removal in the clinic. You have to take that patient to the operating room. And so specifically in kids, it takes sometimes longer to put them to sleep than it does to do the procedure. So as short as like literally a minute, and as long as the longest case I called in Broken Man, Motorcycle Man, was 18 hours. And we literally took shifts. Anesthesia had to wake the patient up to, make it maximize, put him back to sleep, or we would reposition and that kind of stuff. But yeah, it just varies. It depends on what you're doing, but usually trauma cases are the longer cases.
Thank you. So the hardware pin cases, so how long do those typically take? A couple of minutes or an hour?
It can, if you're putting hardware in, so like we're doing an ankle, usually can be about 1 hour, maybe less. If you're doing a closed reduction, which means that the skin is not cut, you're actually just manipulating the bone under x-ray. So, it's lined up, and then you do pins through the skin. That could be like 15 to 20 minutes. It just varies.
Thank you. And another question I had, follow up to the ORIF. So I wanted to, can you tell us more about the ORIF and when it's used and how it's used?
So open reduction, internal fixation basically means I'm going to cut the skin, figure out the jigsaw puzzle of the bone pieces that may not be perfectly lined up, reduce them with an internal fixation. So that means a plate, screws, a rod, that kind of thing to line them up, and then remove, putting the muscle pieces, if you will, the muscle planes, the fascial planes back together so the arm or leg or whatever is going to function normally now with that implant. And so that's when we say open, means there's actually going to be an incision. Internal fixation is usually the hardware that you're going to use, versus closed, no incision, and percutaneous through the skin fixation.
Thank you. And are there alternatives to joint replacement surgeries?
So the alternatives at this point are joint replacement for hip and knee are superb. I mean, people have a better quality of life, can work longer, live longer with more productivity, that kind of thing. Patients today, if they don't get a knee replacement, some people still do knee scopes to basically, if you will, give some time before they may need a knee replacement. But once arthritis sets in, no one really knows if there is a timeline. There's no guaranteed timeline of just if you have mild arthritis, if it will advance to severe arthritis, or if it's just something that you'll have to live with a little bit of pain or mild pain. But when you get to a point where the pain is so severe that you cannot tolerate or it changes your activities of your daily living, that's usually when people should get a knee replacement. Other than that, prior to that, we do basic things. Physical therapy to strengthen the muscles in and around the joint. We can do injections, usually 2 types. There's a cortisone injection that can usually last about 3 months. That stops some of the inflammation in the joint. It doesn't change the arthritis. And then the other thing is we call hyaluronic acid type of injections, which is like oil job for the knee, if you will. And those have sort of fallen out of favor, but in theory, they do last a little bit longer than a steroid injection. And then otherwise, it's just a moderation of how people's joints, if they have a varus knee, which means it's sort of angled in, versus a valgus knee, means it's angled out, puts more pressure on the inside of the joint or the outside of the joint. We can do bracing, specifically called unloader bracing and that kind of stuff. When you talk about things like shoulders and wrists, sometimes the arthritis is so severe and you're either talking about a shoulder replacement for the wrists, even up to a fusion, which basically when we scrape the cartilage down and lock the bones together so they don't move. No movement means no pain. So there's different things that we can do depending on how severe the pain and arthritis is.
Thank you. And speaking of arthritis, what are some causes of osteoarthritis?
So definitely wear and tear, trauma. So, those athletes that have had football injuries and, end up having neck pain later on, car accidents that hurt your knee or your legs or ankle, malalignment. So instead of a straight knee or straight leg, again, you have a valgus or a varus type of knee. Usually it's caused something, could be genetic, something like rheumatoid arthritis, that can cause inflammatory responses that destroys the cartilage in the joint. So there are different things that can cause it. But for the most part, if it's seen early enough, we can try to help slow it down in the sense of the pain.
Thank you. And this question is asked by Dia. What effects can bad posture have on your spine? And are there any serious complications that can arise due to this?
Okay, so bad posture would probably begin in adolescence. Usually, specifically, I did an article on iPhone, I hurt. And one of the ones that we talk about is bad posture with holding the phone, or how you're looking down with your iPad or your computer. It can be how you slouch with your shoulders, and it can eventually affect the spine, the neck, that kind of thing. It takes a little time. There is no rhyme or reason to when it's going to affect and who it's going to affect. But the idea is that any type of malalignment will set you up for increased pressure along a joint surface, which can cause arthritis. So the idea is to have the better posture. Sometimes that's bracing, there's back braces, that kind of thing. Even for people that have back shoulder posture, they even have harnesses that can be put on the shoulders to pull your shoulder back. And then just, I think be aware of, like I'm telling my kids not to lay on your stomach when you're in the bed watching your iPad or whatever. My son's real bad about that, because that actually puts more pressure on the curve, the lordosis part of the spine, which can cause arthritis later on. So yeah, definitely being aware and being told, and then trying to make corrective changes.
Thank you. And what are some preventative measures for osteoarthritis?
Preventative measures are definitely exercise. So, we put patients into physical therapy. It's like strengthening the muscles in and around the joint, and then alignment as well. So if we know that the patient has a malaligned knee, trying to correct that with a brace or something like that. There's been several studies that show inactivity causes more progression of arthritis. So staying active, even if it's just walking, non-weight bearing activities such as pool, like being in a pool and exercising in a pool, takes no pressure. There's no pressure on the joints. So that's the best activity to do.
Thank you. And what are some tips you have for, I know younger kids, as you mentioned, there's text neck, which has been rising due to the iPhone usage and phone usage. So what are some ways we can combat this? And I know that we still don't know any long-term effects of these effects of our phones when it comes to the blue light, the circadian rhythm, giving it to kids at a very younger age. So what are your thoughts on that? And if you want to open up a discussion.
Yeah, I think it's very important. So I talk about, the tech neck is sort of the down. They've even talked about there's bone spurs that come off the back of the head and the neck at the base of the skull. Eye tech, the wrist. So basically, holding your phone like this and doing the selfie elbow. People can get like a tennis elbow, which is, the outside of the elbow type of arthritis and or pain, inflammation, I should say. And then definitely the selfie thumb, or the texting thumb is one that we've seen more irritation, inflammation, tenosynovitis for kids than we've ever seen because of the texting thumb. I'm not sure if you guys ever watched the Kardashians, like Kim Kardashian had to go into a hand specialist, orthopedic specialist, because she had been doing so much texting and selfies that, it was causing a problem for her thumb and her wrist. So very, very much so the education, the awareness, and changing the habits, I think is what's most important.
Thank you. And our next question is from Faizan. Does it help to have more physical strength as an orthopedic surgeon?
Great question. I think it's twofold. So you want to be able to lift a patient. You want to be able to pull a hip or that kind of thing. And I'm fairly strong, but I'm not a super Hulk like physical person. I believe it's about technique, and it's also about drugs. So if you have a great numbing to whatever the area is, so the person's not fighting you, relaxation if you have to take them to the operating room or even in the ER, conscious sedation, with enough relaxation and or your technique of doing the procedure, you pretty much can do anything. So Yes and no. It's good to have the strength. Is it totally needed? No. Have I seen some women that are smaller than me, have less strength than me, that can do some things? You better believe it.
Thank you. That actually leads into my next question. Why did you choose to pursue orthopedic surgery, given it is known to be very male-dominated?
I'm that woman that says, if you tell me no, that's what I'm going to do. So it was definitely told that you cannot do this. I was even pushed almost out to say, this is a male field and you don't need to do this. You should go and do another, woman's field like peds or rehab or something like that. And that came from one of my attendings in ortho. I think a lot of it is a best kept secret. It's a hidden secret that I think a lot of the orthopod males don't want us to know about, have kept the secret for themselves. And so now the field is wide open. This year alone, we had 19 Black women orthopods that became residents, and that was a huge number for the year. So I think the tide is changing. But for me, it was about there was no one there for the representation of women, specifically Black women. So I think I'm definitely into the game changing and opening that door for the next person.
Thank you. I really appreciate that answer. Just moving on to steroid injections. So what are the indications of intra-articular steroid injections in osteoarthritis?
Usually there's some type of inflammation. So these are patients that already have some type of arthropathy, like a rheumatoid or something like that. Recent trauma that has not gotten better with just physical therapy and over-the-counter NSAIDs. So for me, it's one of those patients that have arthritic changes on an X-ray. They don't want surgery. They've not done well with physical therapy, and NSAIDs are not working anymore. So Motrin, Aleve, Advil, that kind of thing. Those are the patients that usually I would do an injection on. But again, you try to do all of the other modalities before you get to that point, because most times we can't do an injection for every 3 to 4 months.
Thank you. And what is the cause of frozen shoulder and how do you manage it?
Frozen shoulders, there's different theories. Some people believe that diabetes has some type of role play into the inflammation in and around the shoulder. For the lack of a better way to describe it, it looks like and it's almost like spider webs, if you will. And for whatever reason, sometimes it's trauma that can cause it, but totally idiopathic. People just, can wake up with this thing and no reason. And it literally just locks up the shoulder that any type of motion will hurt severely. So most of these patients are treated everything from 1 month up to 2 years it can take before the shoulder starts thawing out, is what we call it. Injections definitely can help in that period of time, but usually physical therapy, a painful physical therapy is part of the progress. At worst case scenario, we take them to the surgery and do the manipulation under anesthesia. And most times it actually does move. It's not frozen like what you think, but for the patient, you would think their arm is totally broken.
Thank you. And what is the difference between frozen shoulder and bursitis?
The frozen shoulder, again, is inflammation of sort of that total area. Bursitis is a sac, if you will, that is above the shoulder joint itself. Usually it helps nourish the tendons. And so the bursitis is just like an irritation of that area because the tendons are moving, so friction. Different entities, frozen shoulder is more widespread, if you will.
Got it. Thank you. And Claire asks, as an orthopedic surgeon, how would you characterize the role or importance of patient relationships? And do you typically see patients once or long term? And does that affect your approach to patient interaction?
Patient interaction is huge. I mean, that's your bedside manner. So it's also your hallmark. If patients don't like you, they're not going to refer the patients to you. You get a bad name in the community, that kind of thing. So you have to be able to have a relationship with that patient, because I could tell you what to do, but if you don't have a great relationship with me or you don't believe that, then more than likely they're not going to do what you ask them to do. So that goes along with treatment and how well they're going to do coming back and that kind of thing. Usually I can tell if the patient has bought into what I'm recommending. So part of that is education. You have to sit down and talk to someone just like I'm talking to you guys, of like, listen, this is what it is. This is how it happens. This is what we're going to do. This is what we're expecting, and then I want you to come back and let's figure it out, kind of thing. So it's a buy-in as well. It's a partnership. Your medical care, especially in orthopedics, is a partnership.
Thank you. And what is the day in the life like for a traveling surgeon? For example, does it mean you have multiple hospital affiliations?
Currently where I'm at, no, but in the past and other, just depends on the type of facility that you're at. You can be at several hospitals and clinics. So currently I'm at one hospital, but I cover several different entities. So it's a Navajo Nation, but it covers Hopi, Zuni, Akomo, Chinle, and sometimes even Apache Indians that they come to this facility for care. It's a level 3 hospital, but we do level 1 trauma. So we send out to other places. I get called by, I think, 16 different hospitals for patients that are coming in. So I cover a large area, almost 4 states. But in a small one place, they all sort of come to that area. So it's a lot. A day in the life is you're on call. Usually I'm on call the whole week. So you get tired of calls at 1 or 2 in the morning, 3 in the morning. You have to get up sometimes at 4 in the morning for the drunk that has broken their leg or whatever. It can be clinic on top of having to go to the operating room to see patients that have fallen during the day and you're going to have to admit to do surgery late that evening or whatever. So it can be very, very busy. And again, it depends on location and the population that you're dealing with.
Thank you. And what is the most complex case you have seen, and approximately how long did it take?
Most complex has to be a spine surgery, and it was actually a spine infection. I believe it was almost an 8-hour case in the sense of, have to remove, get down to the dissection that had already been cut through, cleaning out the infection itself, being very, very delicate around the spinal cord, and then trying to, wash out and come back several times. It was like, I think almost 4 times before we can get it clean and actually come back and put hardware in to stabilize that patient. It was very tenuous.
Thank you. You also mentioned that you were a joint and hip arthroplasty surgeon. So then you're also doing spine surgery, you're also doing trauma. So I feel like you're very multidisciplinary in that sense.
I think so. It's like you have to be able to, as a general orthopod, you have to be able to do everything and know when you can't do something, though, and be able to send it out. You need to be able to know to refer and be confident in that. Some people can be a little cocky and want to do it all, but know when you know that you can't do something and send it out for the patient.
Thank you. And during COVID, elective orthopedic surgeries were on hold. So how did you manage that time that you had?
We still did trauma, though. So just because electively it was like we weren't doing knee replacements, there were still people that were drinking and driving a lot more, actually, because I guess, we were frustrated. Everybody was COVID fatigued. So it was more of a lot of trauma. There was a lot of domestic violence where I was. So we did a lot of fractures, stab wounds and that kind of thing because of domestic violence as well. So orthopedics and medicine did not stop just because of COVID. It actually made it worse.
Right, thank you. And what is the difference between orthopedic or general orthopedic centers and shock trauma centers with orthopedics?
Subspecialty that you have doctors there that are just going to be, specifically on certain calls of orthopedics or general trauma, joint, hand. So those orthopedic centers are very, very subspecialized. Shock traumas are usually a general orthopod or a trauma orthopod. But you may have a hand person that's there that's on call or whatever else. But again, those are going to take on general trauma that usually a general surgeon is taking care of that patient, and orthopod is a consult.
Thank you. And are there any exercises we can practice to get steadier hands if we want to be a surgeon?
A lot of people say gaming right now. Like if you guys can do any type of the hand-eye coordination with gaming and that kind of stuff, it increases your dexterity, your being ambidextrous, as well as your eye-hand coordination. So yeah, play some games.
Thank you. This is the first time I've heard this, so that's interesting. Thank you. And we're usually deterred from gaming, but yeah, that's very interesting to know. Thank you. And our next question is, why is it important to you to promote minorities in STEM and medicine?
For me, it was about exposure. We don't have, I never saw a Black doctor, I never saw a female doctor. And so it was about exposing more people for a field that is financially awesome. Like the fact that you can make 6 figures, it takes a long time, don't get me wrong, creates a sustainability, not just for your household, but your community, because I can do more now for my community. So it's a financial stability as well.
Thank you. And what are your thoughts on the social determinants of health when it comes to post-clinical outcomes for patients undergoing a total knee or hip arthroplasty?
Post-clinical outcomes?
Yes, so sometimes a PT same day discharge, 30-day ED returns, post-clinical outcomes in that sense.
For a knee replacement and hip replacement, they are the best outcomes right now. So for most of us that do hip replacements and knee replacements, patients literally can go home the same day. After, I think recently with COVID, a lot of patients went home the same day because they didn't want them in the hospitals with COVID patients. That can be a post-trauma or whatever else. Now, for the most part, hip replacements are still number one, and for pain and resolve for activities of daily living. And then the knee replacements number two. Shoulder's not there yet, elbow and wrist replacements, ankle replacements are still new, fairly new, in the past 20 years or whatever. So they're good, but it has to be almost the perfect candidate. You know what I mean? It almost has to be the perfect patient with the perfect lifestyle that is going to match for those type of replacements. So.
Thank you. But I've also read some literature that the social determinants of health kind of plays different races at different risk factors when it comes down to their clinical outcomes. So I believe that Black Americans have poor post-operative outcomes when it comes to even these total joint replacements and total hip replacements. I know that you're driving, so I want to make sure that you're focusing on driving.
Yes. I'm going to put my camera off. I think it's true, but it depends on their education. And so it depends on their education as far as who can, their feeling about it, and so the Black population has not trusted doctors in the healthcare because of various reasons. So that's even part of this whole COVID hesitancy and vaccination hesitancy. We haven't had a huge sense of trust in the medical care, in the medical field. And so that does lend towards their recovery and how well they do. That is part of it. The other thing is that African Americans, Hispanics, Latinos are likely to wait almost too late. Like when we're saying a stage 3 or stage 4 and this patient is somewhat healthy, they can get a hip replacement or knee replacement and have a better outcome versus someone that's 80 and waits until, it's almost too late to finally get a hip replacement or knee replacement, are definitely going to be more likely to do worse. African Americans may tend to be more obese is another thing that is those are the patients that usually need the hip replacement or knee replacement. But at the same time, that definitely lends to more comorbidities. So it's multifactorial, it's very complicated, but the research has been there, to show that they sometimes don't do as well. But there are studies to show that the satisfaction and the return to activity of daily living, as well as the fiscal side of being productive in society, is huge, and specifically in African Americans.
Thank you. And there are various medical specialties that limit the age groups that they can see. So for example, in internal medicine, you're mostly treating adults, and in pediatrics, you're treating children. So are orthopedic surgeons able to perform surgeries on patients of all ages?
Oh, yeah, definitely. It just depends on the hospital that you are at and your credentials. Like, some places I don't necessarily want to do spine. So therefore, the hospitals that I'm at currently, I don't request spine I'm blanking on the word, credentials. Like, I don't request that I have that capacity to do that kind of thing. But some hospitals, if you're a general orthopod, that's exactly what they want you to do. They want you to be able to do anything and everything just in case. And again, that goes back to knowing what level you're comfortable with and when you're not. So if I get a pelvic fracture, I can stabilize it, put an X-fix on, but I'm going to put it on a helicopter and send it out to take care of it.
Thank you. And this question is about rotator cuff tears. So can you repair rotator cuff tears without surgery?
Without surgery, meaning no arthroscopic?
Yes.
They don't heal. So basically rotator cuff are the 4 muscles that are around the shoulder girdle that basically give you function and motion. Some are very, very small, but the idea is sort of like if it's torn, it's torn. It's not going to heal back. It doesn't scar in. Some people get better with physical therapy and can live with it. But once it's torn, it's torn. And so depending on the size of it, how much pain they have, if they don't recover with physical therapy, Or if it's a massive tear, then you know you're going to have to do the shoulder surgery itself, which can be arthroscopic and or considered a mini open, depending on the damage done, the tendon that's left, and the quality of it.
Thank you. And can you tell us more or discuss a little bit about the ACB or the adductor canal block, and if you know if it improves post-clinical outcomes versus not performing the adductor canal block?
That's actually an anesthesia question. I believe that most patients do very good with an adductor block because of the length of time for the anesthesia, and that they can get home and they can be comfortable. So I actually tell a lot of my anesthesiologists to do any type of block because they usually do better. But it's not without type of morbidity as well. So the patient needs to know that as well.
Thank you. And can you tell us a little bit more about the relationship between the anesthesiologist coordinating with the orthopedic surgeon based on every patient's different case?
That's a loaded question. We have a love-hate relationship. It's like, it seems like the anesthesia are always going to try to help us for the most part, but they are very, very quick to stop a surgery or block a surgery. So it depends on who you have, who the anesthesiologist is, and that relationship you build with them. But for the most part, we all work together for the best care of the patient. And they will tell you quickly, this patient's very, very sick. We're only going to do a spinal, or we're going to do a block, or can you get this case done in 2 hours versus, putzing around and doing 5-hour case. So it just depends. It really does. It's very, very, it changes place to place.
Thank you. And can you tell us more about the different types of anesthesia? I know this may be an anesthesiologist question, but I know that you also have some insights. For example, the general versus neuroaxial anesthesia and how you make the decision with the anesthesiologist.
For me, it's usually the patient going home, the patient's going home and they pretty much are independent. Sometimes a block is not necessary, or it's also their pain tolerance level. You can tell sometimes when I'm reducing a fracture in the emergency room that this patient is going to be really, really hard to get comfortable even after surgery, or the compliance, like a patient that I know that gets a block may end up walking on the splint or something like that, after ankle surgery or whatever. We may keep them in the hospital longer than versus a patient that I trust, and I'll send them home with a block. So again, patient to patient is a cooperative thing between ortho and anesthesia to make that decision.
Thank you. I know that there are 4 joints in the shoulder, like the AC joint area. So which joint is most prone towards injury?
For which one? For AC?
Yes.
So the coracoid-clavicular is the ligaments that can be torn, or the AC itself is the AC ligament. So there's usually 5 or 6 different types, and 1 through 3 are the ones that are not need surgery, and 4 through 6 are the ones that do need surgery, and they can tear the coracoid-clavicular ligament. So for the most times when you see a patient in the ER, usually it's a 1 through 3. When you get to the major ones that are over a 4, 5, or 6, they usually have such a malformation and definitely need a sports medicine doc to fix that, because there's so many different types of surgeries that can do that. And the rehab time with physical therapy, again, takes a great relationship with your sports medicine doctor and that patient to make sure they get a great outcome.
Thank you. And just a follow-up question to that. For shoulder arthroplasty, do you replace all 4 joints or just the impaired joint?
For shoulder arthroplasty, it depends on if it's a fracture and or if the rotator cuff is torn. So if you have a proximal humerus that has been fractured and it's at the neck and the head is split, then they're going to need a hemiarthroplasty. If the joint itself, the glenoid joint, is actually arthritic, then you may need a total shoulder, which means the glenoid socket has to be replaced as well, but sometimes it doesn't have to be. If they have a massive rotator cuff, then they may need a reverse total shoulder. So again, it depends on the fracture, the damage done, and how far their rotator cuff, or if it's functioning or not.
Thank you. And just shifting to, I guess you could say, general advice questions. What is some advice you have for students, especially females, who are interested in pursuing orthopedic surgery?
I'd say get us some thick skin, because it's because it is still a man's world. They're going to try you. There's something called Speak Up Ortho, hashtag Speak Up Ortho, and on Instagram and Twitter right now, that really lends to some of the disparities that we've had to go through to become orthopedic surgeons in a men's world today. Sadly, don't get me wrong, it's not always pleasant. So with that, you have to get some thick skin, build an alliance with a mentor or someone that you trust. It may be male or female, but that's someone that has your best interest at heart. There's a difference between a mentor and an advocate. An advocate person is someone that's going to speak on your behalf and go to battle for you. I've had a great, Dr. Johnson was my mentor and advocate, versus I had a female mentor that wasn't in orthopedics, so she didn't really understand everything I was going to, but she supported me and gave me direction on what to do and how to do it and when to do it, that kind of thing. So definitely those two things. And then, be smart and be prepared. Unfortunately, you are going to have to be the smarter one or the better surgeon in the room, usually, because you're going to have to try harder and do more, show up more. So it is harder, I think, for women still, but hopefully we're changing the narrative now.
Thank you. And what is the meaning of success to you?
Happiness. If you've succeeded and you have a passion about something that you're doing, and that you're happy with where you are in life, that you can also pass that on to someone else, to show them the way, and how that looks for them may be different, but you support them in that. So happiness for me, and then again, paying it forward for the next person, because what I go through in my life can not only be for me, but it has to be for someone else as well.
Thank you. And just a follow-up, can you elaborate more on what makes you happy and how does that lead into your success?
Oh, definitely. I love my kids. I mean, everything I do is for my kids. The way I've chosen being a locums and traveling doctor to everything from, what I do for them and giving them the luxuries of life. It's definitely for my children. I think also legacy living for me, what makes me happy is being able to say I have a clinic in Haiti that is helping other people. I have a book that is going to help generations to see things in medicine they may never seen before. So my happiness is definitely helping others.
Thank you. So what motivated you to write your book?
Because no one else had written anything. There wasn't really anything out there that basically sort of helped give you those key points to say, influence, social media 101. What should you do and what should you not do? About being a good Samaritan, stopping to render aid when you can. About you're not God. Miracles still happen. Medicine is still unpredictable sometimes. And then rule number one, trust no one, because we're in a very competitive field. It's not about going to make friends in hospitals and clinics and whatever else. I'm there to do a job. And most of the time, so I have to look at the x-rays myself and see the patient myself and, those kind of things. You can't always trust people because you don't know their motives sometimes.
Thank you. And speaking of motives, what motivated you? I'm sorry, I only asked that question. How long was your book writing process?
Over years. I slowly put it together. It was not something I was wanting to do because it called for some transparency on my part, including some of the pains that I had to go through. So it was a lot.
Thank you. And how can we improve our writing skills? And what tips do you have for students who are interested in writing and sharing their stories?
I'm sorry. I think I got with a writing group that was actually a medical writing group out of Stanford that sort of initiated the thought process. And then I had a person that sort of held me accountable that basically was like, okay, are you writing? It was starting small, like with ideas, and then elaborating on those ideas with stories and feelings and emotions. And sometimes it was very discombobulated, but in the end, putting it with an editor that can bring it all together for you. So can't really necessarily do it all. I mean, I'm a good writer, but I'm not super, super great writer. So it was more about making sure that I had somebody else to help me along the way. The editor's one person, then you have a proof editor, a content editor, and then there's a whole PR side of all of this too. So it's a lot. It's actually a lot. And it takes definitely, once I was solid on the writing, over 2 years.
Thank you. So you're mentioning editors and proofreaders. So at what stage of the process did you get editors involved and publishers involved, and how did you approach them?
That was at the 1 year mark, like when I started to really decide this was going to come together, and I needed the content editor. Basically helps you with the flow. So it's like this is not flowing together. This rule should go here, this part should go here, this shouldn't be in this book at all. So that's an outside person. I would start early on to make sure that you're writing in the right direction. So you almost can go with your content of like, this is what I want to do, and this direction I want to go. And they can tell you like, yeah, that's not going to work, or this is even better. So it start earlier than later. And there's different areas that you can look for those people, those editors, if you need to.
Thank you. And when it comes down to publishing companies, publishers, how did you choose your publisher?
I did self-publishing partly because I wanted to be able to own my content. When I'm currently been working with a publicist. Most of the companies want you to change the book. And so I didn't want to change my initial content, and I wanted to own that initial content. So I wanted that copyrighted first. What's in the Library of Congress, as well as what I put out, was all originally me before it was going to be changed. And so if I'd come out with a second, third edition, and the content changes to hit a broader audience, that will be the only reason I change it. But the first one was all about me doing it. So that's why I decided to self-publish. I think it was also critical at this point for the people to sort of see that self-publishing, you can own it and it not be, Random House or Penguin, that kind of thing. Don't get me wrong. I would love to get a deal with them, but I knew I was going to have to change a lot of what I wrote, So this way, when you put it out as self-publishing, you own it, and it's all your original content mostly.
Thank you. Yeah, I really appreciate how you're owning your content and it's your own truth and you're speaking your truth. I really appreciate that.
Yeah.
And how do you manage your work-life balance? I can see that you're already juggling your kids' lives with your own work life.
Yeah, I am. You have to have a team. And I say this all the time, that the team is very important for you to be able to do it all. So I have a new podcast that is about having it all. Can you have it all? Yes, you can have it all. And it's always asked to women for whatever reason that we can have it all. And it's like, why is that? And it's like, because the roles of our society have always dictated that we took a subservient position and or a backseat to men's goals and dreams. But I say women can have it all. I do say it comes at different times and different phases of your life. I went through residency and I got pregnant my last year of residency, and I caught hell for it, but I also had a miscarriage during that time that I can never tell anybody about because they didn't understand, nor did they care. So there's different reasons why to have people in your life. I had great nannies. We had a housekeeper that could help. Once you start making a little bit of money, you pay for services that are convenient for you. Would I like to cook all the time and that kind of thing? Yeah, but that means going to the grocery store and then cleaning up afterwards and whatever else. So it takes a village to raise children, to have a family, to live life. I have friends that are in academic medicine, and they have people that help write for them and help write with them. They don't just do it themselves because they're still in practicing medicine. So you need to build a team that can help you achieve what you want. That may be services, that may be apps, that may be people. It would be great to have family. My family was not really, really close, but when it really counted, they were here. So that's a great another aspect of coming back to that core of community and family. Our church, being a large mega church, we have a lot of people that we have in our closer circle that have helped with our kids along the way too. So it takes a village. It really does.
Thank you. And I know that you mentioned a podcast. Can you tell us more about your podcast? I know that you want to serve others. So can you tell us a little bit more about how your podcast is also serving others?
So the one podcast we actually have is the Dr. Dance Mom. My daughters are competitive dancers, and just sort of giving that perspective of that other side of being a mom and being in the dance life and being in the competition life, the expectations of children and adults and that kind of stuff. And then the new podcast about having it all really speaks more to women about whatever field you're in life. It's like you can't have it all. It's about being strategic. It's about understanding your passions, your goals, and then being able to execute on those things in a very timely fashion and understanding those seasons in your life.
Thank you. I also want to ask about females in the workplace and in medicine in general, beyond orthopedics. So how do you believe that you are an advocate for females in general?
So recently we started the Black Women's Orthopedic Surgeon group, and our visionary was Dr. Ida Brown. She's in New York, Harlem Ortho. And it was more out of the disgust for the racism and disparities and diversity, equity, inclusion in America. And then we really noticed it in that most of the Black female orthopods were not even connected, and it was like almost like we're isolated and we feel lonely and we feel sort of neglected, if you will. And so we came together after George Floyd and started talking about how to support one another with our mental health, our emotional, our financial, and all these other things that nobody else was looking out for us. So that's part of the advocacy. The other things I've done in the past, again, were for kids, for my Sloan STEM, and even to an organization that I still hold, but we do more of the mentoring private on an executive level called Motivating and Empowering Women to Excel. And I help entrepreneurs start their businesses and that kind of thing. So in paying it back and giving people their passion and helping them see themselves do more, be more, that is, I think, where I've been very effective.
Thank you. I really appreciate that. I'm sure many students are appreciating your services to others. How do you relate multitasking with your productivity and your health?
With my health, I think it's about timing. Products, as far as products that I use or I'm promoting, I don't understand.
Productivity in terms of how productive you are when it comes
productivity. Scheduling. You've got to have a great schedule and calendar and that kind of stuff. You guys definitely work with my assistant. She keeps me on track, to the point of everything from a Google calendar to an Outlook calendar to scheduling things that I only pick certain days to schedule things. Like today being Saturday was because I was out of the country. And so we got back into the country that I did a Saturday. Usually I don't do Saturdays specifically for kids. So for me to be productive, it's like during the day for my children. I do things when I know they're in school or they're away, or I have time that is locked in just for that. If I'm working, it's harder for me to do anything because I really can't focus on those things. So productivity wise, it's really about picking and choosing the dates and times that you know that you want to do things. I think that goes back to also making sure it's about mission. I call it mission driven. Like if it's not something that you want to do and you're not passionate about it, then don't do it. I recently got approached to do a talk about mental health in kids, something or another like that. But that's not my forte. That's not where I'm at. I can talk about some mental health things, but again, it's not my forte. So I chose not to do that lecture or whatever else. But then being an international lecturer, talking about mental health from an orthopedics woman, that's a whole different ballgame. I don't mind doing that one. So it just depends, but pick and choose your battles and not be all over the place, be mission driven, I think.
Thank you. And for our last two questions, I had a question about the mental health when it comes to professionals in the medical workforce. So I know that you're focusing on African Americans and women. So what are some tips that you have for rising African American students, females who are rising and applying to medical school now, and what they should keep in mind for medical school and residency and beyond?
So first they need definitely get a mentor, because you don't know it all. And it's very overwhelming. It's very, very overwhelming for anyone, I think, going into medicine right now. But understand, I think the sky is the limit, or I won't even say the limit. It's like, it's unlimited at this point, that minorities are at a great advantage at this point in history because of everything that's going on in the world today, as well as I think technology hasn't leveled the playing field, but it's allowed us to be a little bit more competitive in that sense, versus, me going in and having to interview live, or having people that can speak on your behalf. A lot of that can be done more interactively through networking virtually than it ever was in person. So case in point would be one of the guys that was in my medical school class. His dad was, the chair of some department in another state or whatever else. And his dad played golf with, our department chair or whatever else. Well, today, I was able to connect two of my mentees with the president of a different organization virtually, and they could do Zoom calls and whatever else. 10 years ago, that didn't exist. So technology has helped us connect easier, network better, and that kind of thing. So get a mentor, definitely network, use technology to your advantage. If that's how you study, getting extra notes, connecting with people that may have the information that you want, utilize that. So yeah, those would be the things.
Thank you. And for our last question, do you have any book recommendations for students? Because your book, The Rules of Medicine, is definitely on my reading list.
The other book I would definitely recommend is by Pat Heim, Heim, Pat Heim, and it's called Hardball for Women. And it's a business book, but it is basically speaking to our mentality and how being a woman in business, medicine, whatever, has dampened our effectiveness. And so, case in point, it says, let me see here. Case in point, she talks about girls are taught to be nice, to be sweet, to play with dolls, to nurture the baby, to hold the baby, to love the baby. Our color is blue. I'm sorry, pink. It's soft. It's a pastel. You're taught to keep your legs closed. Don't speak. You want to people please. You're here to find a husband or a mate or whatever. These are all things that we're taught growing up. Media has pushed this and that kind of thing. Versus a boy is taught early on, blue is a primary color. He's hard. You're supposed to play hard. You're supposed to, be a team player. You're supposed to suck it up. They throw the ball. You go get the ball, And so you have these two different mindsets from very, very early on that continue as we get older. And then you get to a C-suite level, or you get into an operating room, and that mentality of, I'm supposed to be nice. I'm supposed to keep my mouth closed. I'm supposed to make sure everyone likes me and everyone's happy. But if I'm a team player and I'm not hard and I'm not whatever, that's not ladylike. Or if I am a team player and not hard, I'm a bitch. So it's a dichotomy we fight amongst ourselves and in our own mind because of what we're taught, what media has taught us, what we've seen, what we've heard. So the book speaks to a lot about that and how to break that out of that mold. So it's called Hardball for Women by Pat Heim. And so women going into medicine and specifically surgery, I would definitely say get that book.
Thank you. I'm definitely going to add that to my reading list as well. Thank you very much, Dr. Sloan. We truly appreciate you taking the time to answer all of our questions. This was a greatly informative learning session for all of us. I'd love everyone to please give a warm thank you to Dr. Sloan in the chat box for this incredibly informative session.
Thank you guys. I hope you guys have a great day. And then let me know if you have any other questions. I'm on Instagram at Sonia Sloan MD. Twitter and Facebook. I am Sonia Sloan, MD. All right.
Thank you so much, Dr. Sloan. Now we're going to conduct our closing session with our quiz and future session dates. The link to the quiz for the session is now live. Again, you'll need a 70% or higher to pass and receive certification, and the link is in the chat. Many of our students have expressed interest in pursuing a leadership position in teleshadowing. We do have positions open on our leadership page as we strongly believe in extending opportunities to others. And you can look at the link in the chat now. Don't forget to join our mailing list if you haven't already, as we send session and quiz reminders right to your mailbox. You can join from the link in the chat now. Now on to our next session dates. These dates will also be posted throughout our social media outlets, so be sure to follow us at TeleShadowing. I look forward to seeing you all at our next session next Saturday on August 7th at 10 a.m. Eastern Standard Time with our physician mentoring us in anesthesiology and intensive care. Thank you so much for everyone for attending today's session. We hope to see you in upcoming sessions as well. This concludes this week's shadowing session.